what are the patients going to see that'll be important to them? And we asked for what kind of questions you all were getting already about healthcare reform from your patients, and one that keeps popping up is, am I still going to be able to see my doctor? Am I still going to be able to go to the same place in the same way? And you've all kind of touched on it in different ways, but when these changes happen, when we have these joint ventures or ACOs or whatever they happen to be, how is this going to be different for the patient when this relationship comes about, when things change? How do you foresee your patients, how is this going to change for your patients, you know, when all these changes come through, when they have an electronic medical record that follows them around, which maybe in 4 or 5 years? How is the world going to look different for them?
So what everybody always asks, well, how is this going to affect access to care, you know, as thing moves forward? And if in the healthcare bill, it was talking about raising Medicaid payments to the level of Medicare. Well, the government's broke, the state government's broke. It's certainly easier to allow Medicare to float down to meet that requirement for Medicaid to match Medicare, as opposed to bring Medicaid up. And that certainly, you know, with this occurrence may be the plan, or maybe the solution, you know, for the government that's broke. And that's certainly going to affect all of us on the margin side. And when I say that on the margin side, of being able to sustain ourselves.
When you look at it from the patient standpoint, will they be provided more access to health care through the uninsured that could be insured? If there is more access provided for the patients, then the patients will have some choice to go to where they would like to go, to the primary care or to the hospital. And I think you're going to have to define the value that you're going to bring. You know, how do you differentiate yourself from another facility? And we're all going to be measured on a lot of the same things. There's HCAP scores, patient perception. You know, there's quality indicators out there. There's going to be a more educated consumer potentially, so they can just go to the website and compare and make those choices. And I'm sure physicians will be a part of that process too, when physicians come into the system and their piece of the continuum is measured as well.
So more for people to actually objectively compare when apples to apples.
Right. And I think, unfortunately, I mean, if there's a premium change, folks will change their physician. I think some of the younger generation will change with the premium change versus some of the older generation who has a sense of loyalty with a particular practitioner.
You shop around more.
Right.
Now, in the long run, if this is a successful reform, over the long run, patients are going to see improved quality as hospitals compete on measurables that they haven't been seeing that. They're going to basically see better health overall as people have more access to preventive care, and the overall health of the population improves. And so those are things that they're going to see. But in the short run, obviously they're not going to see that. They're going to see mostly the burden and not the benefit. So in the short term, there's going to be a lot of individuals who are going to be discomforted by this. None of them are going to be traumatized. It's not such a critical issue. But it's going to be uncomfortable for many levels of our patients. But some will openly benefit. And in the long run, I think benefits will.
At this time in the state of Georgia, you've got the lowest number of physicians accepting Medicaid than ever before. And if we've all of a sudden got this huge influx of a bunch of new Medicaid patients that are paying 68% on the dollar, it isn't going to happen. You're just going to have even less. It's going to put a greater burden on our hospitals, put a greater burden on the academic centers from that standpoint.
So the safety net takes that.
Yeah, absolutely. The flip side, though, if, going back to the long run here, in terms of the payment reform things that are in the bill that include projects on patient-centered medical home, the ACOs, things like that, in terms of looking at new ways to pay physicians and to provide higher quality of care, better continuity of care, will be in models like the patient-centered medical home, where you have patients basically assigned to a physician that takes full responsibility for their care in terms of coordinating their care, terms of making sure that they're getting all the preventive things that they need done up front, where you're getting first dollar coverage of those preventive things, spending a little bit of money up front to save a lot of money in the long run. Those are the things that are going to be really beneficial, that I think patients will enjoy a much greater and better health care over the long run. Even just a 10-year time frame could make a huge difference, because then you're not just paying to move, physicians are not just being paid to move people through and work on a volume basis. They're actually being measured in terms of quality, what we've been talking about, of how well are you taking care of that patient, as measured and benchmarked against your peers, and are you doing a good job, so that those who are doing a good job will be better paid than those who are not doing a good job.
You know, patients when they walk in may not see a doctor. They may see a dietitian. They may see a physician, a nurse practitioner, or PA. That's going to be very evident, just because of the huge number of new allegedly insured, anyways, patients that are going to be run through the system. So they're going to see some change there. They're going to see some change because hospitals are going to be held accountable financially for things like readmissions. So we're going to be caring for those patients even after they leave the hospital. So they'll be getting phone calls or maybe visits from people. These are new models that haven't even been developed yet. But I do think we're going to see different care models established to try to react to the different payment mechanisms there.
Because the incentives start changing.
Yeah.
Those individuals that have not had insurance up to this point, I think there is going to be a frustration because I am supposed to be covered and I need a physician, therefore I should be able to go see a physician now without any issue. It goes back to my previous point. I know we don't have the capacity in the system, the excess capacity to handle these additional 30 million folks that at some point will need health care. If you have an existing relationship with a physician, I think and you got insurance, I think things will kind of roll along. I think you may be a little frustrated with how it may be administered, as far as your relationship to your employer or the insurance company, but
That's already there.
yeah, that's already. It may get a little more frustrating, but I think from that patient that has not had insurance and now has insurance, how do I get to see a physician? I think probably key to this is, and we've already have these in place, is federally qualified health centers. I think we need to. I think you're going to have to develop more of those, and like Jim mentioned, you're going to see PAs and nurse practitioners under the supervision of one or two primary, that you can actually deliver more care to those now insured individuals without the high level of frustration, being sick. And then ultimately when you get to that point, it's like, where's the old fallback? Hospital ER, here I come. And that's a very, very, very expensive means of getting your healthcare issues addressed, when you could have them from a preemptive standpoint taken care of in a clinic, federally qualified health center, or obviously a doctor's office.